key positioning and terminology terms for you to know. Anatomic position. Every x-ray that I do needs to be sent to the radiologist in anatomic position. All of your movements for radiology, all of your angles for radiology go back to anatomical position. What is anatomical position? This man is standing in it. The body is erect. The arms are out by the sides with palms turned out. Okay? Review your body planes. You should know these basic planes. Difference between oblique and transverse. Sectional images, they are done in CT or MRI, but if you know your planes, your sagittal plane, coronal plane, or transverse plane, they're the same idea. The skull has two planes. Difference between posterior and anterior. This is extremely important for us in X-ray. A lot of the terminology refers to how you're supposed to place either the beam or the patient. So anterior surface of the body is also called the ventral surface. Posterior surface, dorsal. The foot surfaces are either plantar or dorsal surfaces. There are two surfaces of the hand, either dorsal posterior or palmar anterior. These general body positions, they refer to body positions in X-ray. Basically, how is your patient positioned? The two main ones that we use are supine and prone. Supine, they're laying on their back, prone on their stomach. Recumbent is laying down, erect is standing. There's Trendelenburg and Fowler's, they're on the next page. Stand by, I'll get there. Trendelenburg, head lower than feet. Fowler's, feet lower than head. I remember that Fowler's because of the F and the L for feet lower. Fowler's. Modified Sims position or Sims position. This is the position that we use to place the tip into the patient's rectum for barium enemas. Lateral positions. What does lateral position mean? It means a side. We're doing a side view or your profile shot, okay? Recumbent means standing. So this girl is recumbent. She's standing up. She is in a sideways position. So she is in a rect lateral. And laterals, we determine which side is closest to the image receptor. So we are saying that this is a right lateral position. The technologists put their right lead marker there, identifying that this is the right lateral. This gentleman here, he is recumbent, and his left side is closest to the table. The cassette or imaging plate is underneath him. So this is a left lateral position. Obliques. These are always fun to understand, all right? So obliques are always termed by what body part is closest to the IR. It's either going to be a posterior oblique or it's going to be an anterior oblique. You got two options. So knowing your posterior anterior body portions is important. This gentleman up here in the corner, the posterior part of his body is touching the imaging plate. Which side is closer? His left. This is an LPO, left posterior oblique, and he's erect. This patient underneath him, she is simply recumbent, but she is in an LPO as well. Her left posterior part of her body is closest to the imaging plate. When you flip them reverse, this is an RAO because his anterior body, part of his body is closest to the board, and his right side is closest. So right anterior oblique, the right anterior is closest to the board, and he's standing. She's in an RAO, she's just laying down. Decubitus. Decubitus positions are when you have a horizontal beam. What does that mean? The beam is not coming from the ceiling. It's essentially shooting across here, okay? She is in a left lateral position. It's an AP projection because it's going through her anterior, exiting her posterior. We named the decubitus by the side down. So left side down decube. This is a right side down decube. It's just a PA because we're entering his posterior, exiting his anterior. Dorsal or ventral decubitus, whatever side is closest to the table. So remember that posterior part of the body is called the dorsal surface. His back is closest to the table. You have a horizontal beam, dorsal decubitus. The patient's now prone. The ventral or anterior part of the patient is touching the table. Horizontal beam, ventral decubitus. Radiographic projection. What does projection mean? It's essentially the path of the central ray or the X-ray tube beam. It's entering the anterior part, exiting the posterior, hitting the imaging plate. This is the AP because it hits the A first, exits the P. And the reverse over here, he's in PA. The beam is entering posterior, exiting anterior, hitting image receptor. Enters the B, exits the A. AP or PA oblique projections, these come into play because of anatomical position. So the foot, this is considered an AP oblique foot. This is considered a PA oblique hand because if you remember in anatomical position, the patient is standing with their palms facing front. Now we're entering the posterior oblique because they're PA. Lateral projections, there's either lateral medial or medial lateral, and those go back to the anatomical position as well. There are some projection terms. Anytime you see axial, axial is when the central ray is directed along or parallel to the long axis of a body. This is a superior inferior. This beam is entering the superior part, exiting an inferior part. Semi-axial, this beam is coming down and going along the nose. Inferior superior, this beam is entering the inferior part of her shoulder, exiting the superior part. Tangential, tangential is when the central ray skims the surface. This beam is skimming the zygoma here. This beam is skimming the patella. AP axial lordotic chest projection, this patient is angling their body instead of angling the tube. Transthoracic lateral, what does this mean? It means your beam is going through the thorax to get to the shoulder. Why would we ever do this? If this shoulder was broken and they couldn't move it, I would use this option. Let's see. Projection of the foot here. So this is a dorsoplantar. So this X-ray beam is entering the top, exiting the bottom. So remember, dorsal surface, plantar surface. This view of the calcaneus here, it enters plantar surface, exits dorsal. These are some unique head projections. Relationship terms. These are key for X-ray. Medial versus lateral. All right? Medial part of the body, lateral part of the body. Proximal versus distal. Distal is always in the direction closest to the digits, either fingers or toes. Proximal is closer to midline. Tube angles. It's either going to be caudad, away from the head, or cephalad, toward the head. Flexion and extension. That's pretty basic, right? Ulnar deviation, radial deviation. It's in the word. So ulnar deviation, the wrist deviates towards the ulna. Radius deviation deviates toward the radius. These are for feet. So dorsiflex is bringing the toes up towards the ceiling. Plantar flexion, toes down. It kind of reminds me of like ballerina toes. Stress movements of the ankle will either be either in or out, and the radiologist does these. Medial versus lateral rotation goes back to anatomical position. So when you're in anatomical position, the palm is pointed out. If you move this hand out to towards the thumb, that's going to be a lateral rotation. If you move in towards the body, medial rotation. Abduction versus adduction. Abduct is away. Adduct is towards, remember, bringing towards the body or adding to the body. ADD. Supination, pronation. I remember supination because someone told me if you have a cup of soup in your hand, your supination. If you've dropped the soup on the floor, you've pronated. For chin movements, retraction is to bring your chin back. Protraction is out. Shoulders, elevate shoulders or depress shoulders. Circumduction, circular around. Rotation versus tilt. Are you tilted or are you rotated? Superficial versus deep. Radiographic view. We don't tend to use this term, although you might hear it sometimes at the clinical site. What view do you do? essentially view means that the body part is seen on an image receptor or other sort of screens. All right, I'm going to stop there and go